Good morning, everyone. A very warm welcome and thank you for joining us today at NCCS Virtual Cancer Wise Workshop on coping with sexuality after prostate cancer treatment. I am Wen Siu, the facilitator for today. Before we begin, there are a few pointers for your kind attention. All attendees' mic will be muted by default. You may pose your questions using the Q&A function found at the bottom of your screen here. Please ask topic-related questions only. Thank you. Today, we are very privileged to have Dr. Swee Do Soon to speak with us on coping with sexuality after prostate cancer treatment. Dr. Swee Do Soon is a consultant endocrinologist with subspecialty interests in andrology and reproductive endocrinology. He underwent endocrinology and internal medicine training in SingHealth institutions and was accredited as specialist in 2016. He then completed his clinical fellowship in andrology and reproductive in UK from 2018 to 2019. In 2020, he is qualified as Fellow of the European Committee of Sexual Medicine, FECSM, European Union of Medical Specialists. He currently runs a regular dedicated men's health clinic at SGH Diabetes and Metabolism Center, managing conditions relating to testosterone, hypogonadism, pubertal and fertility disorders. Ladies and gentlemen, please welcome Dr. Swee Do Soon. Dr. Swee, please.
Hi, good morning, everyone. It's really a pleasure to be here today. And I'm grateful to the organizers for this opportunity to share with you on the topic of coping with sexuality after prostate cancer treatment. Let me share my slides. Right. I hope you can see my slides. The scope of my talk today will cover the following. I will give you an overview of the impact of prostate cancer treatments on sexual health. I will talk about the sexual rehabilitation concepts, as well as medical therapy for treatment of erectile dysfunction after treatment for prostate cancer. And I'll also cover on the topic of androgen deprivation therapy, associated metabolic health issues, as well as general health and well-being issues arising from this treatment. Let me start off with prostate cancer treatment and sexual health. Prostate cancer is the most common cancer in men. Fortunately, survival rates for prostate cancers have increased remarkably in recent decades. In the UK, the survival rates of prostate cancer have more than tripled over the past 40 years. Now we are seeing very high 5-year survival rates for men diagnosed with local or regional prostate cancer. And certainly, men are living well beyond the treatment of cancer nowadays. With that, we are faced with survivorship issues in our patients. Indeed, the trade-off of effective treatment is the medium to long-term side effects that can significantly affect the health and quality of life in our cancer survivors. These survival issues, these side effects are diverse, ranging from sexual dysfunction to metabolic health and virility due to muscle loss. Many of these side effects result from treatment that suppresses testosterone production as part of the cancer management. Many men with prostate cancer receive androgen deprivation therapy, in short ADT. In the US, more than 1/3 of prostate cancer survivors are receiving ADT. While ADT improves the clinical outcomes dramatically in many of these patients, it comes with a variety of adverse effects that may impact their long-term health. However, because of the side effects, there's increasing interest in interventions to mitigate the long-term outcomes of cancer treatment, including sexuality. Sexuality is indeed a difficult topic to talk about. It is seldom discussed in the consultation room. So what exactly is sexuality? Sexuality has a complex definition by WHO and is comprised of the following three components. First, it's a central part of being human, a very essential part of being human throughout life. It encompasses sex, gender identities, role, sexual orientation, erotism, pleasure, intimacy, as well as reproduction. It is expressed and experienced through thoughts, fantasies, desires, beliefs, attitudes, values, relationships, and so on. And is also heavily influenced by the interaction of multiple factors, including biological, psychological, cultural, religious, and even spiritual factors. So as we can see for the definition, sexuality is more than just sexual activity. In fact, sexuality is not about who you have sex with or how often you have it. It's about your sexual feelings, your thoughts, your attractions and behaviors towards your spouse, your partner. Sexuality is diverse and personal. Your sexuality may be different from mine, may be different from the other person, but it's certainly an important part of who you are. It defines your personality and your attitudes toward life and your quality of life, certainly. Therefore, it is very important to recognize the impact of prostate cancer treatment on sexuality. Here, I have outlined the three major treatment modalities that are used in most prostate cancer patients: surgery, androgen deprivation therapy, as well as radiotherapy. First, I talk about surgery. Surgery involves the removal of the diseased prostate by your surgeon, namely the urologist. Sexual side effects that can occur after prostate removal surgery includes that of erectile dysfunction, lack of ejaculation, or sometimes also known as dry orgasm, changes to the orgasm. So orgasm may occur without erection or may be even associated with incontinence. And some may even notice that the penile length is shortened following the treatment. Radiotherapy has similar side effects on sexual function as per surgery, but is generally of slower onset, and the worsening of the sexual function tends to be more subtle and takes a longer time to occur. So men may experience progressive erectile dysfunction, may increasing progressively reduced semen volume. And on the right-hand side, it's also mentioned that the sexual function can actually, erectile dysfunction can be delayed in onset between 6 to 36 months after therapy. On the other hand, androgen deprivation therapy is associated with a wide-ranging list of side effects. It affects sexuality in more than just the domain of sexual function. It indirectly impacts on sexuality through its effects on metabolic health, as well as general health and well-being. And the reason why androgen deprivation therapy has such wide, diverse impact on sexual health is that testosterone has many actions in the body. It has an important role in the maintenance of many aspects of men's health. Indeed, testosterone is not just a male hormone that mediates sex or reproductive function. It is vital for the preservation of muscle, bone health, bone marrow production of red blood cells, as well as cognitive function and mood regulation. Therefore, lowering the testosterone does indeed bring about many diverse symptoms. However, ADT has an integral role in prostate cancer management. It is recognized that prostate cancers possess androgen receptors, and testosterone could promote the growth and survival of prostate cancer cells. As such, in certain clinical settings, patients are prescribed medication known as a GnRH, either agonist or antagonist, in order to suppress the testosterone production in the body. The duration of ADT that one receives would vary according to the severity of the prostate cancer. So ADT is an important part of care in prostate cancer, and the intended effect of the ADT is to suppress testosterone to very low levels in order to deprive the prostate cancer cells of testosterone. it delays disease progression and increases survival rates in certain disease states. Therefore, it is very important part of prostate cancer, and one may not be able to escape from this mode of treatment. Testosterone is fuel for libido. Sexual desire is heavily dependent on testosterone's action in the brain, and erection is in turn dependent on sexual arousal and sexual drive. So with this ADT treatment, the lowering of testosterone levels would inevitably cause a reduction in sex drive, as well as leading to erectile difficulties. Erectile dysfunction occurs when one is unable to achieve or maintain an erection that is firm enough for penetration. ADT-related sexual dysfunction can be distressing. There's a common misconception that the reduction of sexual drive actually alleviates the distress from sexual dysfunction. Sexual dysfunction is probably one of the most commonly reported symptoms by prostate cancer survivors, which has great impact on their quality of life. It can be stressful for both partners and patients, especially if they don't have adequate knowledge of the adverse effects of ADT. Moreover, no matter whether it's Western or Asian culture, men are often reluctant to discuss their sexual interest and performance, even with their partner. And this sadly may result in the eventual withdrawal of emotional and physical intimacy completely. So besides the direct impact on the sexual function, ADT brings about a variety of potential non-sexual side effects, including the following metabolic disorders: obesity and increased insulin resistance, leading to increased risk of development of diabetes, reduction in the muscle bulk and strength, also known as sarcopenia, as well as accelerated bone loss, leading to osteoporosis and increased risk of fractures, such as spinal fractures and hip fractures. ADT also can affect a patient in other ways through its effect on psychological symptoms. Hot flushes is probably one of the most common symptoms that one may experience following ADT, and that directly results from the reduction of the testosterone. That, along with the earlier metabolic disorders that I've described, lead to fatigue, poor sleep, and mood changes. Some men may experience prominence of the breast tissue following ADT. And the reason why it occurs is because ADT alters the ratio of the testosterone to estrogen in the body. Hence, that may favor the formation of breast tissue over time. So this condition is called gynecomastia. And that can really affect how one feels about himself sexually. So for this first section, the first summary, this is my first summary slide. Prostate cancer treatment is highly successful these days, and it has greatly improved survival rates for many prostate cancer patients. So now we should turn our attention to managing long-term sequelae of treatment, because it is an important determinant of quality of life in our cancer survivors. And of all the side effects, sexual dysfunction following treatment is very common. It's probably difficult to voice out by patients, yet is probably one of the most important issues to address early in order to overcome and to arrive at a successful treatment. Androgen deprivation therapy has both direct and indirect adverse impact on sexuality. And it does so by directly affecting sexual desire, leading to erectile dysfunction, and indirectly through its impact on the masculine image due to physical changes, the metabolic health disorders, for example, muscle wasting, and general symptoms, fatigue, hot flushes, and so on. I move on to my second section of my talk. So here I'm talking about multidimensional approach to the rehabilitation of sexual health during and after prostate cancer treatment. The objective of rehabilitation is to restore the patient's ability to engage in intimate interpersonal relationships. It incorporates the optimization of self-esteem as well as bodily function. So in my mind, rehabilitation can be broadly divided into sexual rehabilitation and penile rehabilitation. So sexual rehabilitation will largely involve dealing with the more psychological aspect of the rehabilitation program, and penile rehabilitation will probably deal with more of a physical aspect of the rehabilitation efforts. Of course, they are intimately intertwined, and we have to deal with both at the same time. Rehabilitative efforts should be and must be started early in the journey of the prostate cancer management. Knowing what to expect from the treatment is vital to managing expectations regarding the realistic chance of recovery of sexual function, so that appropriate coping strategies can be developed. And that is greatly beneficial in the reduction of anxiety and stress. Therefore, one of the first steps in sexual rehabilitation is actually open discussion. So open discussion between patient and physician, and open discussion between patient and partners or spouse. So it's important to recognize that all prostate cancer treatment, no matter whether it's surgery, radiotherapy, or ADT, can affect men's erectile function. And it's important to recognize that men's erectile dysfunction can affect partners and couples' intimate relationships. Not forgetting partners. A partner's sexual function and expectation can have significant effect on erectile function recovery and satisfaction. So these couples sometimes may need support to help them recover their sexual relationship by the acceptance of an aspect of the relationship that's been lost. I will elaborate on this a bit later. Following open discussion, your doctor will assess and help you understand some of the other non-ART related pre-existing medical condition and lifestyle factors that could also influence potential sexual responses. So some of the patient factors that can affect recovery of the erectile function include whether there is any pre-existing baseline erectile dysfunction, whether the patient has any other pre-existing comorbidities, for example, diabetes, which can affect the nerve function that controls erectile function, cardiovascular disease, smoking, because these two also will lead to circulation problem that will have impact on the penile circulation and erection. Depression and medications that patients take for depression can also affect erectile function. So it's important to understand and to be aware of the underlying factors that may exacerbate the problem following prostate cancer treatment. Of course, the treatment factors play an important role. What kind of surgery the patient is going to undertake, the type of radiotherapy, how long is the radiotherapy, and the duration of the androgen deprivation therapy that the patient has to be on for his treatment. Of course, awareness of the available ED treatment is important to help patient make an informed decision. And being fully aware of the rationale for early treatment approach will allow one to persevere through the treatment and not to give up too early, which might jeopardize the chance of recovery. Sexual rehabilitation. It is important to acknowledge that the fear of losing one masculinity is a real concern for many patients, and this arises from the sexual implications, the physical changes, and the psychological consequences of treatment that they are undergoing. If this is not effectively managed, it becomes a psychological barrier to maintaining sexual activity with partners, spouse. Hence, it is not surprising to learn from studies that men with better sense of purpose and acceptance tend to fare better. So even with changes to sexual function, one is still a sexual person and still a masculine man. Sexual rehabilitation focuses on elements that help individual and couple with the sexual adaptation process. So adaptation simply means you are changing ways, finding creative methods to overcome some of the sexual dysfunction that arise from the treatment. Briefly, sexual adaptation encompasses gaining knowledge, understanding what is orgasm, developing coping and communication skills to help deal with feelings of sexual inadequacy, and learn how to talk to your partner about sex. Understanding how societal myths around sexuality might influence personal values, adjusting values and beliefs to help support sexual self-view. Namely, what I'm referring to here is the body image, the masculine body image, and discovering new ways of supporting desired sexual activities and behaviors. To see how this can be applied, let us look at these findings from a New Zealand study on 210 prostate cancer patients on the factors that help them to improve their sexual activity. They can be broadly categorized into redefining sex, preparation, and the importance of the relationship or intimacy with their sexual partner. Redefining sex. Redefining sex is about adapting sexual activity to fit what was now possible. So many respondents indicated that they were no longer able to engage in penetrative sex, but they are able to engage in a range of other sexual acts. And they are able to have an open discussion about post-treatment barriers. And that is an important aspect of these men and their partners in finding ways to overcome these barriers and adapt so that sex will still be mutually pleasurable. This I quote from another paper. A respondent said, "Trying to make love without an erection suitable for vaginal penetration causes shame." Indeed, this is a problem faced by probably many men with prostate cancer after their treatment. Non-penetrative sexual activity is important part of sexual life and it's important part of sexuality. So it will be helpful to focus on other aspects of sexual activity other than intercourse. This can help to reduce the pressures of sexual performance, alter the expectations around sexual sensations and response, and allow one to embrace the prospect to experience new opportunities around sexual activity, expression, and appreciation. Preparation. So men who tend to be able to cope better will also use assistive aids. So they use a range of aids or activities to prepare for sex by initiating an erection. So they may use visual erotic material, and they may also use medications or medical interventions that are readily available to try to achieve erection using drugs, which are going to later, and using a device such as a vacuum pump erection device. Lifestyle changes also very important. In order to have a healthy sexual life, the body must be healthy. And of course, that is through leading a healthy lifestyle and engaging in regular exercise. Thirdly, from this study, men also find that it is important to have an open communication with their partners and spouse so that they can mutually understand what is going on and come out with ways to overcome in order to maintain their sexual activity, even when penetrative sex is not possible for some of them. So it is frequently quoted in many papers that a caring and supportive partner is an important key part of allowing sexual activity to continue healthily in the long term. So partners must be viewed as important part of survivorship care for our patients, because partners or spouse are often distressed too by the diagnosis and treatment. And partners and survivors' distress are mutually influential. So there must be shared decision-making to address both patients' and partners' needs during key post-treatment planning of interventions. Next, I come to penile rehabilitation. Penile rehabilitation, the objective is to keep the erectile tissue in the penis healthy during treatment and recovery period. So this is also referred to as penile circulation enhancement. So one of the concepts is to use PDE5 inhibitor early. So PDE5 stands for phosphodiesterase 5 inhibitor. So we are familiar with one of the drugs we are familiar with is called Viagra. It is a non-invasive treatment with minimal side effects. And it has the potential to preserve and promote recovery of erectile function after radical prostatectomy, as well as radiotherapy. It does so by providing some protective effects on the nerves, as well as the blood vessels in the cavernous sinus, cavernosal tissues in the penis that will be important to regulate erectile function. How does PDE5 inhibitor work? It relaxes muscles found in the walls of blood vessels in the penis. By doing that, it facilitates increased arterial blood flow at the penis. So as you can see from the cartoon, PDE5 normally in our body without medication will narrow the blood vessels. But by using medications that inhibit PDE5 activity, it allows the blood vessels to dilate, and hence that promotes erection during sexual stimulation. There are several types of PDE5 inhibitors available in our pharmacy. In our institution, other than the vardenafil, the rest are available in our formulary. So they include sildenafil, popularly known as Viagra, tadalafil, as well as ebenafil. Sildenafil is taken as an on-demand basis. So the dose range from 25 to 100 milligrams per day, and it's usually taken 1 hour before sexual activity. It tends to last between half to 4 hours. One must remember to avoid taking the tablet with a fatty meal because it will reduce the absorption and hence the efficacy of this treatment. Tadalafil can be either taken on demand or on a daily maintenance basis. Dose range from 10 to 20 milligrams per day and is taken 1 hour before sexual activity. It lasts long, up to 36 hours, and along with the other way of taking it on a daily maintenance basis, this allows for some spontaneity in the sexual activity. So with this, one does not need to time the taking of the medication to the sexual act. Vardenafil essentially behaves, the mechanism is the same as sildenafil. So to take about 1 hour before sexual activity and tends to last about 4 hours. And also to remember to take it on a relatively empty stomach and to avoid fatty meal when you take this medication. Lastly, ebenafil, dose range from 50 to 200. This is short-acting, so it can be taken within 15 to 30 minutes before sexual activity. So the onset is quick and lasts up to 6 hours, sometimes shorter. So PDE5 inhibitors have been around for a long time. They have very good safety profile and they have minimal side effects. So most commonly reported side effects are headache, flushing, dyspepsia, dizziness, and rhinitis. So what I tend to do is I usually counsel on the potential side effects to watch out for and to start at the lower dose. If the lower dose does not bring about any side effect, but it's not satisfactory yet in terms of the effects, then one can try to increase the dose, while watching out for any occurrence of side effects. So one of the factors leading to poor compliance to this treatment is that there is fear of it causing heart problem. Really, unless one is on certain medications or has an unstable heart disease, there is really seldom contraindication to taking these tablets to enhance sexual activity performance. So contraindication include any concurrent use of nitrates. Nitrates are tablets, either one that takes during an episode of chest pain, put on the tongue, or one that takes on a daily basis to reduce the angina symptoms, chest pain symptoms. Yeah. So if one is taking any form of nitrates, then the use of PDE5 is generally contraindicated. If one has a heart attack, stroke, or life-threatening heart rhythm and abnormality in the past 6 months, or has very unstable blood pressure, either too low or uncontrollably high, or is known to have a chest pain during sexual intercourse, or has significant heart failure, then the use of PDE5 inhibitor probably is unsafe. While so many patients are also taking alpha blocker as a form of blood pressure control meds. So if one is taking an alpha blocker, you have to be careful when you're using PDE5 inhibitor, because that may lower BP, the blood pressure excessively, leading to giddiness, and the worst case scenario, fainting. So I mentioned earlier, PDE5 inhibitor has been shown in some studies that when it's used early in the treatment process as in the prostate cancer treatment process, it has some protective effects and may enhance the recovery of erectile function later on. But there are several factors that may lead patients to stop taking it. So they may find that the treatment effect is below their expectations. They may lose interest in sex because the partner is not interested anymore, or their partner has other medical conditions. Psychological factors, for example, the loss of masculinity, as I described earlier, or they find that their erection recovery is slow and painful. Of course, some men may be concerned about cardiovascular safety. So to overcome this, it's important to manage expectations, to know the potential effects of the treatment, and to form a realistic idea of how much of erectile function may be recovered after prostate cancer treatment. So one might not see a good effect immediately in the first few doses. Might have to persevere for a longer period of time, knowing that the goal is to maintain penile health through the treatment and following treatment, so that can increase the chance of recovery of erectile function in the future. Certainly, involvement of partners is always important for therapy continuation. If PDE5 inhibitor remains unsatisfactory, or one has a contraindication to taking PDE5 inhibitor, then you might discuss with your urologist regarding other options. For example, vacuum pump erection device, which briefly generates a negative pressure to promote erection, or the use of intracavernosus injection, an injection into the penis with a tiny needle to promote erection. So there are other methods that can be discussed and may be suitable for some men who might not respond optimally to PDE5 inhibitor alone. So this is a summary slide for my second part of my talk. So early rehabilitation facilitates recovery and development of coping mechanisms to improve sexual health. Open discussion is key to understanding treatment-induced changes to sexual function. Sexual adaptation involves the acceptance that a certain aspect of sexual function will be lost, the flexibility to come up with new ideas, new ways to engage in sexual activity, and to be open-minded. Of course, accepting that penetrative sexual activity might not be possible. Of course, patience and persistence will be necessary, because sexual adaptation is a process, and it's a process between patient and partners. So a degree of patience and persistence will be necessary to allow the process to be successful. Communication and feedback between partners is key. PDE5 inhibitor is generally a safe and inexpensive treatment. When I say inexpensive, I'm referring to because there's generic sildenafil available these days. So it is greatly affordable for many patients now. And this treatment has potential to optimize penile erectile tissue health and should be considered if one does not have any contraindications to taking this treatment from the early part of the prostate cancer treatment process. This is the third section of my talk. Here, I will cover on the several measures that can help to counteract the metabolic and general health effects of androgen deprivation therapy. A recap of the effects of androgen deprivation therapy. So we have talked quite a bit about its direct impact on the sexual health, the changes to the sexual function that can be induced by the androgen deprivation therapy, particularly the reduction in the sexual drive, namely libido. Its impact on metabolic health, which include muscle and bone loss, fat mass, insulin resistance, and its general health symptoms of fatigue, hot flushes, and sleep disturbances. So metabolic health and general health issues do have great impact on sexuality and should be managed accordingly to optimize health and sexuality. Muscle loss, also known as sarcopenia, is generally referred to as age-related decline in the skeletal muscle. It leads to mobility disorders, increase in risk of falls and fractures. Because of the reduction in the muscle strength, there is now reduced physical function, leading to impaired ability to perform activities of daily living, leading to disabilities and even loss of independence. So besides aging, testosterone is an important determinant of muscle mass in men. Androgen deprivation therapy reduces muscle mass by 3 to 4% during the first year of treatment. With longer term use, there is continued muscle loss at the accelerated rate. With muscle loss, it contributes to the effects of ADT on physical function and quality of life, leading to the sensation of fatigue and loss of energy, and hence the inability to carry out the activities of daily living, of activities of relating to recreation. This would severely impact on the quality of life of this man. Androgen deprivation therapy also has an effect on the body composition. With treatment, the fat mass to lean mass ratio actually increase even at 3 months of therapy. After 1 year, androgen deprivation therapy increases the weight by about 3% and fat mass by about 10%. And with longer term treatment, fat mass continues to increase, but generally at a slower rate compared to the rate of rise during the initial treatment. What happens when there's increased mass and decreased lean muscle ratio? It is accompanied by metabolic alterations, particularly insulin resistance. Insulin resistance is a state of abnormal glucose regulation. So your body tissues are less sensitive to the insulin that you are producing. And if this worsens, it can lead to prediabetes and diabetes. And that is definitely a risk factor for development of cardiovascular disease in the future. So metformin is frequently used as a therapy in our patients with prediabetes to prevent the progression to overdiabetes. And also is a common treatment used in diabetes, in patients with diabetes to reduce the insulin resistance. So besides the changes to the lean and fat mass, androgen deprivation therapy also accelerates bone loss, and it leads to osteoporosis over time. As you can see from this graph, healthy men beyond age 65 to 70, there's a normal physiological bone loss at about 0.5% per year. But for one, if one is on androgen deprivation therapy, the rates increase up to 9-fold. So the rate of bone loss can increase to 4.6% per year in the spine. So as you can see from here, that androgen deprivation therapy leads to bone loss quickly in the first year, and that continues over time. And if there is significant bone loss over time, it would then lead to osteoporosis. Osteoporosis is defined by the presence of low bone mineral density on BMD scan. So BMD scan is frequently done as a screening tool to evaluate bone health in our patients. So with a T-score of -2.5 or lower, patients are then diagnosed with osteoporosis. Osteoporosis brings about an increase in the risk of development of fracture, particularly in the spine, it's called vertebral fracture, as well as in the hip, called hip fracture. So ADT has been associated with 21 to 45% greater risk for development of clinical fracture. Hence, it's important to preserve bone health in men on ADT. The simple thing to do is to ensure adequate intake of calcium between 1,000 to 1,200 milligrams per day, and vitamin D3 between 800 to 1,000 IU units per day. In fact, vitamin D deficiency is also a common cause of poor energy, fatigue, muscle weakness in many patients. So just by adequately replacing vitamin D can actually help in many aspects of health preservation. If men, despite these measures, still are at high risk for development of a fracture, or they have established osteoporosis, then there is medication available that has been approved for prevention of bone loss and fracture in men on ADT. So this medication is called denosumab. It's a 6-monthly subcutaneous injection, which means it's an injection under the skin, done by either nurses or doctors. And it is a very safe treatment with minimal side effects. And as you can see from this graph here, after 3 years of treatment, there's a reduction in the 60% relative risk of spine fracture. Hence, it is an effective treatment for one who is at a high risk of significant bone loss and osteoporosis. It is also possible to counteract the effects of ADT through exercise. So supervised resistance and aerobic exercises have beneficial effects in maintaining bone health, in maintaining muscle strength, improving cardiovascular fitness, and in turn, this will improve fatigue, energy levels, reduce psychological distress, and improve quality of life. Of course, these beneficial effects will then enhance sexual well-being, partly through enforcing the body image of masculinity. It is evidence-based. In one study of men starting on ADT, an intervention that combines aerobic and resistance training improved sexual function, social functioning, as well as mental health. And this is a 12-month study of and the study method is randomized controlled trial. So in this trial, resistance and impact training were delivered in supervised classes as well as a home-based exercise. So the investigators focused on multi-joint movements, which are common to activities of daily living. And for the resistance, 3 weights of resistance bands were used. So from this study and from many other studies, we know that exercise is an effective and safe treatment that will improve sexual function and sexuality. So in the community, we do have access to some programs that prostate cancer survivors can participate in. So this one is organized by the Singapore Cancer Society, called the Walnut Warrior Exercise Program. And it's actually an exercise program for prostate cancers, targeted for those who are undergoing hormone treatment, and it aims to improve muscle strength, joint function, mobility, and balance. Besides Cancer Society, other community partners, for example, NTUC Health, also offer gym-based exercise that help to build strength, increase muscle, and improve bone density. So it is possible to look for somewhere nearby where you stay, probably when the COVID situation is much better. And then this participation in these exercises would help to improve general health and improve sexuality. Hot flushes is seldom talked about in men. Hot flushes is a common symptom reported in women after menopause. And it occurs the same way in men who are on ADT treatment. The suppression of the testosterone by ADT leads to low level of sex hormones, and that disrupts the temperature regulation in the brain, hence leading one to feel warm in the upper body, which comes with excessive perspiration. Many men, up to 80 to 90% of men on ADT, experience a degree of hot flushes. And in fact, it may persist for years after treatment. Hot flushes lead to poor sleep, cause one to be irritable, leads to mood changes, and even depression. And all this, it definitely will exacerbate poor sex function. So how do we deal with hot flushes? Hot flushes can be conservatively dealt with by avoiding triggers. So some men recognize that certain spicy food, or drinking alcohol, or even caffeine may worsen hot flushes or trigger hot flushes. So aware of which one is a trigger to avoid it. Cool your environment. Use of fan or air conditioning at night that can help to improve sleep. Acupuncture is a safe complementary treatment that one may consider to help to reduce the degree and the frequency of hot flushes. Exercise is also helpful as well. If conservative or complementary treatment methods do not reduce hot flushes sufficiently, so we can consider non-hormonal pharmacological treatment. It has been shown to be helpful in up to 60% of patients. So some of the medications that have been described in the literature include venlafaxine, agents from this SSRI group, including escitalopram, fluvoxamine, and some other antidepressant medications, including mirtazapine, sertraline, and gabapentin is also frequently used for nerve pain and has been shown to be effective in reducing hot flushes as well. So using these medications would help to reduce both hot flushes and improve sleep at night if sleeping disturbance is also a major symptom experienced by our patients. So this is my summary for the third section of my talk. So androgen deprivation therapy induces a state of severe testosterone deficiency, which can lead to adverse metabolic changes. With the ADT, there is increase in fat to lean mass ratio. So there's a gain in fat mass, simultaneously a loss in the lean mass. Muscle wasting, leading to muscle weakness. Increase in fat mass and obesity, leading to insulin resistance and increased risk of diabetes development. And bone loss, resulting in osteoporosis. This in turn affects energy levels, sleep, mood, etc., resulting in poorer sexual health. Exercise is a safe treatment, especially if one is not conditioned for exercise yet, should attend a supervised either physical or online class that incorporates both resistance and aerobic training. This helps to maintain muscle bulk and strength, bone health, and prevents excessive gain in fat mass. It is also very beneficial in improving masculinity and sexual function. And we must be aware also that there are effective therapies available to manage symptoms and side effects of ADT. for example, hot flushes, for example, insulin resistance, and important also to make sure that vitamin D supplementation is adequate. And all this together will be helpful to improve health and quality of life. So here's my last slide. So this talk, I've conveyed to you the concept of sexuality. Sexuality is an essential part of human experience and contributes to quality of life and well-being. And how sexuality can be affected after prostate cancer treatment can be divided into whether it's sexual function specific effect or whether it's an ADT adverse effect on the metabolic health, as well as ADT adverse effect on the general well-being of our patients. So the approach must be multi-pronged. We must tackle all aspects in order to improve the overall quality of life and sexuality for our patients. Thank you.
Thank you, Dr. Sui. We have come to the Q&A session. I'll read out some of the questions posted. First question, is prostate cancer a sexual infectious disease that can pass cancer cells to a partner, and how to ensure the partner's safety? Thank you.
Prostate cancer is not an infectious disease that is transmittable through sexual intercourse. So it is unlike other STD we are familiar with, like for example, HIV or gonorrhea or syphilis. It's different. So you cannot pass prostate cancer cells to your partner. So there is no restriction on sexual intercourse or sexual activity for one who has prostate cancer. There's no risk to the partner. But for example, if one is in the early stages of, or one is undergoing radiotherapy, because sometimes the radiation oncologists do insert seeds that deploys radiotherapy to the local area, then while the treatment is ongoing, it might not be ideal to undergo sexual activity for fear of the radiation effects on partner. But otherwise, there is no risk of passing cancer cells to your partner.
Thank you, Dr. Sui. Okay, the next question. How soon do you start rehabilitation program?
So I had, this one is important. So rehabilitation program starts even before treatment, because at that point in time, we might not be starting medication yet. We might not be using a vacuum pump erection device. But what we want is to understand your view of sexuality, your view of sexual function, to assess your baseline sexual function, to assess your pre-existing medical conditions, so that we are aware and you yourself will be aware of the possible side effects from the treatment first. What kind of treatment is safe and available to you, and how we can deploy it during the treatment process. Yeah, so it actually starts before treatment. And the first thing is, I had to emphasize this earlier, is open discussion. So open discussion with physician, and it will be, and as it's a couple issue, the involvement of partner or spouse is important. So I would say that when I said early, ideally is even before the starting of the treatment, prostate cancer treatment process. But I do understand that at that point in time, the focus might not be on sexual function. The focus will be on going through the cancer treatment safety and to reduce the acute side effects of cancer treatment. I do appreciate that. But for one, hence, this talk is actually to increase the awareness, knowing that prostate cancer treatment is highly effective, and many men are living well beyond the cancer treatment phase. So if one is interested and one is keen to know about the long-term impact on sexual function, it is good to have a discussion early, so that we can make decision, treatment decision along the way that can help to optimize the sexual function, as well as metabolic health, which I'm personally very interested in.
Thank you, Dr. Sui. The next question, how much is the ADT treatment, and can we use MediSafe?
I think because ADT treatment is, ADT treatment, okay, so I won't be covering this aspect because ADT treatment would be as part of the oncological treatment, which may be delivered either by your oncologist or your urologist. Yeah, so I won't be able to cover the cost aspect of the ADT treatment for that. But if you are talking about the rehabilitation part to overcome the effects of the ADT, then it depends on the kind of treatment that the therapy that might be useful for you. For example, referring to a psychologist who is experienced in the sexual health issues in oncology patients, the use of medical treatment. So I touch on some of the PDE5 inhibitors. Some medications are generic, so are quite affordable, and some are still not generic, but they do have different properties, and some respond differently to these agents. So cost would differ from one patient to the other. And if escalation of treatment is necessary, for example, a vacuum erection device is needed, or injection, penile injection therapy is needed, then there'll be a different costing. Yeah.
Thank you, Dr. C. The next question, what is the success rate of the ADT?
So I believe this ADT, the success rate of ADT is referring to the success rate of ADT in suppressing prostate cancer. Improving prostate cancer outcome. I'm not oncologist, so I wouldn't be able to adequately answer this question. Yeah, but from what I know, it is certainly important part. It's still an important part. That's why it's so controversial whether ADT treatment can be stopped in certain patients or not. Or there is also a concept of intermittent ADT, whereby probably patients of lower risk can come off ADT for a period of time and go back on ADT depending on the risk profile and depending, for example, the PSA levels during the period without ADT.
Thank you, Dr. C. And thank you everyone for your active participation. Some of your questions asked are mainly personal medical conditions, and you may wish to seek advice from your treating doctors. Please feel free to join us or share with your family and friends about the next Virtual CancerWise workshop this afternoon from 12 to 1 p.m. on prevention and management of side effects from lung cancer treatment. You can take a screenshot of this QR code and scan the QR code to register after the webinar. Please help us to improve by completing the feedback forms. The link will appear immediately when you leave the webinar. We've come to the end of the webinar, and we would like to thank our valued speaker for today, Dr. Sidu Soon, and especially everyone here for spending your Saturday morning with us. We look forward to your support and participation in our future events. Thank you, take care, and have a great weekend.